Welcome to Microcap Moments, a podcast from Shore Capital Partners that highlights the stories of founders, investors, and leaders who have taken on the challenge of transforming ideas and small companies into high-growth organizations. The journey of building and scaling a business takes one down many unexpected paths. It's a journey where we learn from our mistakes, fall down often, but have the entrepreneurial grit to pick ourselves up and persevere. Within this series, we will share these stories of success and failure, of the challenges and the rewards faced by those who dare to dream big. And through their lessons learned, we hope to inspire others who are on a similar journey of becoming, growing, and leading.
In this episode, I talk with Corey Waller, who's a physician and executive partner with Shore Capital Partners, whose focus is on behavioral health. Corey talks about his career journey and all of the places in healthcare saying yes has taken him. From physician to emergency medicine to street medicine to tactical work with the Federal Protective Services to starting clinics and editing influential books, and the list goes on. Corey looks for a gap and fills it with the goal of leaving behind something that others can take and own without him. He provides incredible insight on the relative nascence of addiction treatment as a field and how little infrastructure and few systems there are to really support it in a more traditional clinical model. Corey talks about the need to build a system of care where the easy thing is the right thing. He also shares his initial negative reaction to private equity and really any business in healthcare, and how common that response was in his circles, but also how this idea of building systems and particularly sustainable and scalable systems that don't require heroic individuals in every position helped change his perspective. He now sees the opportunity for what he calls, quote, good tension that's critical for delivering ethical and sustainable healthcare.
I'm Corey Waller. I'm physician and executive advisor for behavioral health. I work with the other partners and the VPs and helping to really solve problems related to the delivery of care, the payment of care, and the politics around that care. And as such, I have to do everything from a line-by-line evaluation of the one big beautiful bill all the way to having some one-on-one conversations with the providers to see if I can get them to chill out a little bit.
And you've had an expansive career. We talked previously in your Everyday Heroes episode a bit about your background, but for anyone who hasn't heard that, will you just talk a little bit about your professional journey that brought you to this place?
Sure. I think most of my journey could be summed up by saying yes to everything you're given an opportunity to do, right? You don't gain anything by saying no. So every time I was given an opportunity to say yes, I said yes. And I still pretty well do that. And I think it started with, well, I'm going to go to medical school. That's great. That's a lot of work and time and effort, but it's a real privilege to be able to do that. And then I went to emergency medicine, but then I was offered an opportunity to go do some tactical stuff, which I didn't even really know what that was at the time with the Federal Protective Service, and said yes to that. And got some training and really dug in on intervention and interdiction on the drug side and weapons side of what they did as medical support. And then when I had an opportunity to learn about addiction, I was like, sure, I'll take a look at that and see how it looks. And then went and did that. And then pain, and coalesced all of that really into building a career around identifying things that needed better structure and things that needed support that generally didn't have financial support at the beginning. So trying to come up with a good story of why it needs to exist, how it positively improves that. And I think as the first medical director for the Grand Rapids Police Department, now they've had one ever since, because we found the value in that piece. When I built a clinic at the health system I was at for high-cost complex patients, they've gone from one clinic now to 25 clinics throughout that health system dedicated to that population. And then when I moved on to addiction and pain, they now have an annual course dedicated to that based off of one of the books that I edited around pain and addiction, having to understand the components of those together. So I think most of my focus has been around finding a gap and filling that gap with really validated approaches to care or intervention, and then trying to create something that lives without me afterwards. And I think that's ultimately what got me here, is coming in as really a true clinician. You know, I'm back in the emergency department seeing patients now, and thanks to John letting me to go work some 24-hour shifts. I'm a little crusty on the phone sometimes.
Congratulations, you get to go work a 24-hour shift.
Yeah, that's right. But I'll tell you, it feels like an immense privilege to be able to sit in a room with some exquisitely smart people about finance and business, and then sit there and try to put that together with, well, I had a patient the other night who was this sick and this kind of stuff and needed this help when they left the ER, but we didn't have it. How do we fill that gap? And really bringing that to the portfolio companies in a sense of what is a real practical thing we can do to help people.
And as you talked about systems and structures, I think we've talked before. Can you talk just a little bit about just the perspective that a lot of people wouldn't really think about? But the pain management and addiction treatment industry, so to speak, is relatively nascent when it comes to systems and support. It's something that we've all, I think, known personally, family-wise or otherwise, but don't necessarily think about it being a relatively new industry in that sense. Will you talk a little bit more about that system and support side of things?
Yeah, I would say that, the cowboy days for addiction are still in full swing. They're winding down for pain. But at the same time, everything in medicine comes down to identifying a patient, assessing a patient, treating a patient, and getting them good enough in that disease process to then kind of leave standardized care. Those same four components are, no matter what area of healthcare you work in, those four things have to happen. And in pain, we've almost figured that out as far as how we find patients that really do need pain intervention. How do we do good evidence-based assessments of what their needs are and then apply the therapies that we have, whether that be medication or interventions or surgeries, follow that up with physical therapy and get them functionally back. But in addiction, we're still frustratingly in this space of everybody's bright idea is what we're going to do today, and still doesn't fit the true scientific nature of approach. And how do you find that patient? Well, it's been Google. It hasn't really been the standard, oh, you were at the hospital, you were sick, you should come see us because you need specialty care. It's family members freaking out because they're scared one of their loved ones is going to die. It's that person finally waking up in the street with half their clothes off going, maybe I should get some help.
Yeah.
This is terrible. And I think that's where addiction is still in its adolescence, where it's trying to mature to a point where it's predictable and consistent. And that's been my role, especially, not only with Brightview when I was working there to build those systems, but also as the editor-in-chief of the ASAM Criteria, the book that directs levels and intensities of care nationally. And we published the update for adults. We're about to publish adolescents and then justice involved. And I'm finishing editing adolescents right now and should be done at the end of August. But you just have to define what structure is. And I don't think we've done that in addiction. Close. But once you define the structure, then you can start to compare and contrast how one person runs that structure versus another person. And I think we're still in that tug of war between what does the structure look like and what is the system willing to pay for.
And you've kind of worked this from all angles. You've been sort of working the streets and drug enforcement right through being a physician and then working with Brightview. How has that shaped your understanding of the system and how you're thinking about what you're doing now with Shore and that level of work?
Yeah, well, a couple of themes that I think I've been able to pull from seeing, from handcuffing someone to treating them to treating them in the streets when I was doing street medicine in Camden and just being out in the ether. What I have found is that patients don't decide to have bad things happen to them. Like whenever somebody shows up and sees me in a clinic or in the emergency department, generally speaking, their day is worse than mine. Like it's a real privilege for me to be able to see that. And imparting that on the providers that see these patients is that, look, I'll tell you, if you go out and take a look at the world that they're in, it's pretty bad. And if you can just chill out for a second and actually focus on how to peel that out of them, like what's going on, how do I support that, and where do we go, then I think ultimately you can build a system that works best. And then from the provider side, instead of whipping them for a KPI that looks neat on a spreadsheet, actually recognizing that if you build the system where the right thing is the easy thing, it will always happen. And so anytime that we don't hit a KPI, anytime that we don't, I try to impart this on operators and anybody who'll listen, to be honest, is that before you think it's the provider not hitting the KPI, let's back up and think about how the system is not allowing that to happen and rethink how we're setting up this system where the default is meeting the budget, where the default is meeting that KPI, where the default is creating a happy provider in that setting.
Yeah, I have to think it's also part of the story of the evolution of how you treat people too, right? Like, how do we think about how we set them up for success?
100%.
And not just us up for delivering something that we say should work.
Right. And I think that translating that into anytime that I would hire a new doc or nurse practitioner, PA or nurse or any of those things, one of the questions I would always really ask is like, do you define yourself by this job or is it just a job? And interestingly, most people don't have a ready-made answer for that. So if they hesitate and come up with some blah, 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 then you know that it's just a job. But it's amazing when you ask somebody that question, this is who they are. This is how they define their ethos. You know, they get a sparkle in their eye. They have an in-depth answer. They typically have a nidus moment in their lifetime where this was where they decided this is what they're going to do. I mean, those are the people that you want delivering care. And you want the business to happen in the background. Like I always tell my CFO and operators that I work with, I'm like, don't ever tell the provider who loves their job what impact they have on the budget. They don't need to understand the P&L. You just need to set up a system so that the passionate work they're doing flows into the P&L. But don't ever say, if you saw 2.2 more pay, we got to make that margin. Like, that's the worst thing you can say to an impassioned person who wants to help another human being. What you say is, we have some people waiting out front that could really use your help. What are some ways we can move a little faster?
Yeah.
And you take that way, take the thing that they want to do, and they'll tell you. They'll be like, well, if you just pop them in this other room, get me a medical assistant and help with that. And using that partnership rather than just what I always talk about is there was this episode of The Simpsons, and Homer gets hired by, it gives my age, I guess, although it's transcended age, right?
Yeah,
it's like 40 years old.
Yeah.
But there was an episode where he was hired by another company, and the boss there said, I need you to increase productivity. So he just walks in the room and goes, hey, can you guys go faster? And they go about 7% faster, but that's only going to get you so far. And sometimes I see that that's the most sophistication out of a young operator, and trying to help them to see, like, look, I appreciate asking, and they'll try to please. People want to, but there are things you can do to build that system around them to make their default faster, rather than having them somehow feel like they're doing something wrong.
Yeah, for sure. So this is obviously very difficult work, the world from emergency medicine to pain medicine to addiction treatment. And your experience with Brightview was the first time you've been a part of this work that included private equity.
Yeah.
Will you talk about your concerns that you had going into that? And then obviously you're sitting here today as an executive partner with Shore, how your perspective has evolved given all that you've done.
I appreciate that question in the sense that I'm still suspect of all business in healthcare, and not from a negative, like, I hope it dies kind of thing, but I think we have to be worried about it. And when I first took the job, I said no for 6 months because it wasn't exactly the pinnacle of an emotional, iconic life to say I'm a doctor who's an executive at a private equity-backed addiction treatment company that owns its own lab. Because I had worked in all nonprofits. It wasn't about getting paid. It was just about doing the work. But there's a pretty solid naivety in that, in a sense, that there is work that has to get done. But at the same time, there also has to be a business structure around that in order to continue that work long term. And I felt like when I did come in for working with Brightview, what I found were a lot of dedicated people who wanted to build the business so that it didn't require the overtly impassioned individual to still get people care. Because not everybody is that. Some people, it is just a job. And if that's the case, I still want them to do good. But that requires really good business acumen. It requires building a system where the default is to see that person next and to do a good job and give that feedback. And so once I found that the powers that be were malleable in that conversation, then I felt much more comfortable working in this space. And then, like most things, anytime I'm given an opportunity, the answer again is yes. And so watched everything on the Shore University and watched you guys do a great job putting that out, and really tried to learn the language of the P&L, what add backs mean, how these things go together, so that I could have a conversation with my CFO and the COO in a way that, worked. And it still doesn't always connect because I have a scope of practice that I need to hold and they have a scope of practice that they need, but it's good tension. And that tension needs to be there to find the right and ethical way to deliver healthcare. And that's one of the reasons that I said yes to coming here, is because I think there needs to be a voice at the table that does raise the question with answers, not just poking at stuff, but, is this ethical? Where are the guardrails? How do we build really good, predictable, ethical healthcare in a setting where we want to run a margin, in a setting where we're hoping to have an EBITDA number that allows us to sell a company onto the next thing? Because I think those things can coexist, but they have to be done in an active way. They don't just accidentally happen. And so I feel like my role here is, one, to identify some real good opportunities based on that and find some potholes in some of the data that we see just from a doctor perspective, but really to help identify what those ethical guardrails are and how we move forward with truly honest, ethical companies in the delivery of healthcare.
Well, and I love the idea of tension that you're describing, because I do think that I worked over a decade in the nonprofit sector, and you have people who I describe as heart forward.
Yeah.
And they live their roles.
Yeah.
But it's really hard to sustain when your operations are weak or your financials are weak, whatever, and you have people that are not at the top end of the economic ladder that are working all heart every day, not just sustaining those people, but sustaining the systems that make their work, as you're describing, not a grind, but facilitates their work.
Absolutely. And I think that, in a true yin and yang kind of balance pathway for this, you really have to balance a combination of the MD and the MBA. You can't have too much of the MBA and you can't have too much of the MD. And I always told our COO, I was like, look, I realized that if I was given full reign in this place, I would probably run it into the ground by adding cool new medical things that we want to do. But I also know that if you took over, you would basically run all of our patients away because they wouldn't want to be seen in what felt like a factory. And so not everything is a focused factory model of care. And we have to build in these moments of pause, these moments of introspection, and have that be a part of it. I call it deliberate inefficiency. And that deliberate inefficiency is allowing you to move from one patient where you just had can be an earth-shattering conversation about the death of their family member, the end-of-life decisions that we have to make, and then you move to the next patient. You need some moments to compartmentalize that, so it can't just be bang, bang, bang. And so trying to figure out how to recognize there's a limit on some of this. To know that you helped a company do its work better and more consistently, not just on an EBITDA number, but to know that that equals better care for people. I mean, that's the holy grail of healthcare, is where better care equals an appropriate profit margin. And if you can put those two things together in an ethical way, I mean, that drives everybody in that business, because medical providers are driven by making people better. Business providers are driven by, making a business better. And they both have to have that feedback. Like, I get emotional feedback seeing from the patient, but my operator doesn't get to get that from patients. They don't get that juice. So their juice has to come from hitting a KPI, hitting a budget, doing those things, and recognizing that's just as important to the team as me sitting across from a patient and helping them move through a crisis in their life.
For sure. So when you think about where your work is today, and you think about the complex systems that you've worked with on all sides of the medical world, really, I won't even try to compartmentalize it to addiction treatment because you've mentioned so many other things. How do you stay focused? How do you stay optimistic? How do you stay faithful that you can have the kind of impact that you've built a career trying to get? When you think about just what potentially to me could feel like just an overwhelming, insurmountable challenge, how do you personally, professionally stay motivated and driven?
That's a good question. And, we talk a lot about the business's North Star, right? Personally, I think you have to have your North Star. What are my guardrails? What are the things I will and won't do? What are the things that I will happily walk away from a job for? Like, what are those hills that I'm willing and happy to die on? And I will push as hard as I can up into that point, at which point you pivot. And here, I've never been pushed to any of those limits, but I think that most of that is having that larger North Star of what do I want to accomplish when I'm laying on my bed and this is like the last few breaths. Well, I know that I've done the most that I could have done with like the one shot at this I had. And that has to do with my kids and my wife and work, and really honoring this really moment in time you have to deliver everything and leave it on the field. I mean, when I ran track, I ran the 400-meter hurdles, and that race hurts, especially at the end. But in that last stretch whether or not you're truly leaving it on that track. And I feel like that's what this whole point is to push it forward and make sure that when you've done a job, however small or however a shift in the ER, small task of giving somebody information, was that done at the point where you would look back and be comfortable that you gave it your all? And I think that's what drives me on a daily basis is, have I done the best I can with what I got?
When you think about a young executive, maybe a younger doctor, someone who wants to find a career of service and impact, what advice do you give them based on what you know, what you've experienced about how to approach, whether it's business or medicine, just any sort of key words of wisdom that you come back to people who are looking to build a career that matters, that has an impact on a difficult industry? Any advice?
Yeah, I think the biggest thing is to say yes. Those opportunities usually only come up once and then they're gone. And so if you don't say yes, you don't get a chance to hang out on a Black Hawk with a bunch of people who did cool operation stuff. You don't.
Like you do.
Right. Yeah. Just like on Saturday. You don't get to experience other people's worlds unless you say yes to that. I think that as doctors, especially those of us who've medical school and residency and extra training and fellowships and, all of these things, we have a sharpened blade of skill for that specific piece. You have to exercise these muscles for other things, meaning I need to know about finance. I'm never going to be a CFO, but I need to have a cogent conversation with that human being. I need to understand operations. I need to be able to walk through all of the key conceptual frameworks of the 5 S's and doing a Kaizen and Lean Six Sigma. And I need to know those things. So I would say get out of your known comfort zone where you're going to be the smartest dude in the room no matter what. You can still be that, but you have to be vulnerable and learn from people who are 15 and 20 years younger than you. And I would say that's one of the biggest barriers for physician leaders is that we're always immediately older than everyone because we went to med school and residency. And so we're sitting in a room where somebody's 15 years younger, but not 15 years dumber. They're smart. And so there's a lot you can learn. So you have to really wind back the ego and allow for that learning to happen.
Say more about that, because I think there's, to some degree, and maybe you have your own personal reflections, but it requires a bit of ego to come in and do what you've done and be a doctor and invest in that. How do you balance that? Go back to the idea of tension. How do you balance that idea of, no, I have been trained to be an expert, but I need to listen to someone who's talking about the P&L, but I need to listen to someone who's talking about operations or what have you. How do you personally, how have you navigated that?
Poorly, mostly. I mean, honestly, I think, so I would say that without question, I waved my ego like a flag earlier in my career. As I've gotten older and recognized that most people could not care about it, they don't care. It's just irritating and to most people and to yourself. Like you hear yourself say something and then you apologize immediately. I'm like, oh my God, I can't believe that still came out. So I think that being successful in whether it be being the best surgeon or being, the best operator or being that is about understanding that it is about confidence, not cockiness. And the confidence comes from doing the right thing consistently so that you know what that right thing is. And when something bad happens, that you know that core so well that you're able to quickly utilize that knowledge and pivot to how to fix that problem. But I think it doesn't require ego, other than if you're talking about the Freudian baseline ego strength, the ability to have it. But as soon as that ego moves into not being a nice human being, you immediately start to destruct the thing you've built. And sitting at a table, and I see colleagues of mine where they know a lot of things. And the best advice I ever got, which I struggle to use, is to be quiet. And this is from it was a chief medical officer from a big health system, was so wonderfully compliant in being a mentor for me and allowing me to say stupid things on a regular basis. But his advice to me was there are times in which it's best for you to just be quiet. And it's not because you don't have something to say, not because you don't have an answer. It's not because you probably couldn't fix the problem. It's that other people can also fix the problem, and they need to be allowed to fix that without feeling like they have a parent over their shoulder.
If you enjoyed this episode, check out more from Corey Waller in his Everyday Heroes episode, as well as other microcap moment stories at www.shorecp.university/podcasts or anywhere you get your podcasts. This podcast was produced by Shore Capital Partners, with story and narration by Anderson Williams, recording by Austin Johnson, editing by Real Audiobooks, sound design, mixing, and mastering by Mark Galloop of Real Audiobooks. Special thanks to Corey Waller. This podcast is the property of Shore Capital Partners, LLC. None of the content herein is investment advice, an offer of investment advisory services, nor a recommendation or offer relating to any security. See the Terms of Use page on the Shore Capital website for other important information.